Welcome to our webinar, New Transplant Advances for Patients. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the program online, you can call in to hear the audio portion by using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in the question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming question. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert today cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Corey Cutler, who is the Medical Director of the Stem Cell Transplant Program, the Director of Clinical Research in Stem Cell Transplantation, the Director of the Stem Cell Transplantation Survivorship Program at Dana-Farber Cancer Institute. He is also an Associate Professor of Medicine at Harvard Medical School. Welcome, Dr. Cutler. Thank you so much for joining us today.
Thanks very much. It is always a pleasure to be here with you. I'm hoping that my screen has just come through and you now see the buildings of the Dana-Farber. It's always a pleasure for me to present to this group. I've worked with you guys for many years through your education committees, and so it's a real pleasure and honor for me to do this today. I'm going to spend the next 45 minutes or so discussing advances in transplantation for myelodysplastic syndromes, as well as aplastic anemia. We'll talk largely about the diseases themselves rather than the nitty-gritty of stem cell transplantation and the risks entailed with transplant itself. But I'm happy to take questions when this is over on anything related to transplantation, whether it's regarding MDS or aplastic anemia or not. So we'll start by talking about the myelodysplastic syndromes, simply because I know more about them and they're far more common than aplastic anemia. This audience does not necessarily need the introductory slide. The MDS are pre-leukemic conditions, although we do consider them cancer or malignant. These are diseases that increase with increasing age. And so the majority of individuals who are diagnosed are in their mid to late 60s. And previously, individuals who were young had low survival, only 4 to 5 years before transplant became part of the equation. And for people who are older, those numbers were slightly worse. So why do we talk about doing transplantation in myelodysplastic syndrome? And I'm going to walk you through what's called a Kaplan-Meier curve. This is unfortunately a very harsh way of looking at statistics in transplantation and in medicine, but these are survival curves. And these are 2 trials that looked at patients who did and who did not undergo transplant when they were diagnosed with myelodysplastic syndrome. What you can see is as the curves move from the left to the right, the curves fall because that is associated, unfortunately, with untimely death following either diagnosis or transplant. But for both curves, the transplant arm in solid black on the left and in red on the right ends up at a higher proportion than the patients who do not undergo transplant, the gray on the left and the blue on the right. What this tells us is that over time, transplantation is associated with better long-term outcomes. This is very important to understand, that when one talks about doing transplant, one is investing in a long-term outcome. The curve on the left is from a study done in France. The curve on the right is from a study done in Germany. We have no reason to believe that the data in North America is any different. And I'm going to, in fact, show you some of this data in a few moments. Now, before I go any further, I want to say very clearly, age itself is not a barrier to transplantation. This is from a very large study where we looked at about 1,350 patients who underwent transplant over the past decade. And all of their data was submitted to a national registry called the Center for International Blood and Marrow Transplant Research. And we looked at the outcomes of individuals who were aged 55 to 64, and then individuals who were 65 or greater. And what you can see is that these curves are almost superimposable, which means that individuals above the age of 65, where the vast majority of MDS patients live, did just as well as individuals younger than 55. If we had looked at a cohort of individuals under 55, they might have done a little bit better. But age itself should not be a barrier for patients moving forward with transplantation. And we actually looked at our center at all the patients who were referred for transplantation. So this were self-selected patients. They either came because they wanted to come or came because their doctor said, you should at least go speak to a transplant physician at Dana-Farber. And Dr. Abel followed the data on 400 of these people. And there was no treatment assignment. So patients, after they came, decided, am I going to have a transplant or am I not going to have a transplant? And the curve on the left demonstrates that the patients who decided that they wanted a transplant simply did better than the patients who didn't, particularly if you had higher risk disease. And you all know, using things like the IPSS scoring system, you can determine whether you have low risk disease or high risk disease. And by and large, patients with high risk disease did better if they chose to undergo transplant. Now, what I've spoken about so far were largely retrospective looks. We looked back and said, who did what? We didn't assign people to one strategy or another. But we have now done the largest and what we think is the most definitive trial in transplantation for older individuals with MDS. And this is hot off the presses. This was first presented at the American Society of Hematology's national meeting in December and will be coming out, hopefully, in a major medical journal in the next couple of months. And so this was a national trial where we enrolled subjects at 34 centers nationwide. Why did we do this? Well, part of it was actually motivated by your wallet. It turns out that Medicare, which covers the vast majority of individuals above the age of 65, does not consider MDS a covered condition for transplantation, which makes no sense. Older individuals have Medicare. MDS is a disease of older individuals, yet we were at this impasse with Medicare because they said all of the data does not look forward at what happens to patients, but it's a retrospective look. And in the world of data quality, retrospective looks are less valid than prospectively defined clinical trials. So we were kind of charged by Medicare to perform this trial. So this was what we call a biologic assignment study. Patients came for a transplant consult to one of these 34 centers in the US, and these were all the big transplantation centers. And unfortunately, not everybody has a perfectly matched donor. And on the basis of whether one had a perfectly matched donor or not, one was assigned into the donor group or the no donor group. Patients in the donor group were expected to undergo transplant within 6 months. No one said you have to have a transplant tomorrow just because you're seeing a transplant physician. And this was only for individuals of age 50 to 75, comprising everybody basically with Medicare. And people who are on disability from their disease also tend to have Medicare or Medicaid. You had to have higher risk MDS, and you needed to be a candidate to undergo a low intensity transplant. Now, patients who did not undergo transplant received non-transplant therapy based on the center that they were being treated at. What that means is that if you were at a center that chose azacitidine as what you would get if you were not undergoing transplant, that's what you would get. And if you were at a center where you were going to have transplant using regimen A, B, or C, that's what you got. So we didn't prescribe any of the therapy for patients who were actually enrolled on the trial. So over the course of 5 years, we enrolled and biologically assigned 384 patients. The biological assignment took the place of randomization. You can't randomize somebody to have a transplant. That's not fair. Some patients have strong feelings one way or the other, and you would never want to force a patient to have a bone marrow transplant who doesn't want one. And similarly, patients who are randomized to not have a transplant, but who desperately want to pursue that therapy, you can't force them to not have a transplant. So we used this biologic assignment of whether you had a donor or not, which is out of your control. And that was our surrogate for randomization. And as we expected, about twice as many people had a donor as compared to those who didn't. So 260 with a donor, 124 without. And here is the upshot of that trial. What we were able to show was that at 3 years, nearly half of the patients who had a donor, not who had a transplant, but who had a donor, survived, as opposed to only 1 in 4. This to us was extraordinarily convincing. It was nearly a doubling of the survival rate. That is a large magnitude of difference. And some would say a 3-year survival of 50% isn't great, but this includes patients who chose not to actually have a transplant in the donor arm. Again, they didn't have to have a transplant, but they were analyzed in the transplant arm. So what this tells us is that transplant really is associated with better outcome when you have that opportunity. And we looked to see which patients would benefit. And this is a tricky chart to look at. It's called a forest plot. But at the end of the day, what I can tell you is that it didn't matter if you were less than 65 or greater than 65, if you had MDS for less than 3 months or longer, whether you had intermediate to or high risk disease, or which of the revised IPSS scores you had. All of the estimates were roughly the same, and having a donor was better than not having a donor. Okay, it increased your odds of survival by about 2 3/4. And that's really the message here. Every patient subgroup in this trial actually was benefited by being in the donor arm. Very important, because people are always worried about this. We looked at quality of life, because a lot of people feel that if a transplant is going to be something very hard, very difficult to get through, it might not be worth their while. And so we compared the quality of life of patients who were in the donor and those not in the donor arm, and looked at them over the course of 3 years. And we used a number of different measurements of quality of life. These are questionnaires that many of you might have been asked to fill out at doctor's appointments, but these are very standardized questionnaires that ask you about your quality of life in a variety of different ways. And what I think you can see here is that at every time point, in each one of these 4 different measures of patients' quality of life, they were the same in the transplant and in the no transplant group. And so people generally are afraid that transplant is going to be associated with a decrease in quality of life. In fact, it was not. The quality of life of our transplant patients was just as good, and in fact, a little bit better at a couple of time points. There's an asterisk in the bottom left, and there should have been one on the top left as well, suggesting that quality of life was in fact better at a couple of time points in the transplant group. So the fear that having a transplant is going to impair your quality of life is largely unfounded. So based on this study, what we said was that among higher risk MDS patients, aged 50 to 75, having a donor leads to better outcomes. There's just no other way to interpret it. And we feel very strongly that transplantation should be included as an integral part of the MDS management plan for patients with higher risk disease. Patients with higher risk disease should be referred to a transplant center early in their disease course, and the transplant should be covered by Medicare. I can't fix the first issue about referral, but I can tell you that we are sitting down with Medicare in the next few months to actually discuss their coverage guidelines, and we feel very certain that based on this study and that first one I showed you about age, that in fact Medicare is going to change their coverage guidelines in the coming year to two. These things move very slowly, but we believe that this study, which Medicare asked us to do and Medicare approved the design of, will be integral in having them reverse their decision. I should also mention that we are looking at the cost effectiveness of transplantation versus no transplantation. Those set of studies are being done, but we're working off the data we collected in this trial to look at what type of costs would be incurred by Medicare for going through transplant. And we're actually quite sure that it's going to be very cost effective because 50% of the patients are actually cured. So we do think that that's going to be another piece of evidence that Medicare is going to use to start covering transplantation. So I touched on this a minute ago about the recommended timing for transplant consultation for patients with MDS. So we recommend, and not just we, I should say the National Marrow Donor Program, the Be the Match organization, recommends HLA typing at the time of diagnosis for all patients. Why? Because at some point in your disease journey, transplantation is going to need to be discussed. And so there are several subgroups for patients intermediate or higher IPSS scores. With the bullet points here are some of the clinical features that make an earlier referral more likely. But by and large, typing to get a sense of donors is recommended for all patients around the time of diagnosis. So when should you undergo transplant? Well, this is the older IPSS scoring system. And before we did clinical trials, we tried to do these studies on the computer, what we call in silico trials, to try to use statistical modeling to determine when was the right time to do transplants. When in your disease course should you hit that go button? Because not everybody needs a transplant at the time of their diagnosis. The first time we looked at this, we determined that at some point when patients hit that intermediate 2 risk score, that's the time to pursue transplant. And this was for young people who had matched sibling donors. We then looked at older individuals undergoing reduced intensity transplant and actually came up with the exact same time point. Interestingly, a European group actually suggested that considering transplant when you transition from low to intermediate 1 risk disease was the most appropriate time. So somewhere in that intermediate 1, intermediate 2 risk transition is probably where people should be considering strongly moving forward with transplantation. I'm going to show this curve just to say that waiting until you have failed hypomethylating agents, azacitidine, decitabine, I shouldn't say whether until you failed, but waiting until those agents have failed you is too late. Because once those agents stop working, the likelihood of a favorable outcome with transplantation goes down dramatically. So here these curves bottom out in the 10 to 20% range, whereas I was showing you survival curves of about 50% for patients who are transplanted earlier. So waiting until azacitidine or decitabine stop working is not the right strategy. So I've showed you that the transplant survival was roughly 50%. How do we make that better, right? Because no one will be thrilled walking into a situation where we say the likelihood of a good outcome here is a coin flip. So how do we make things better? Well, we have to make sure we choose our patients better. We have to tailor the transplant to the older patient population. And we have to understand the unique supportive care needs in older patients with myelodysplasia. And I go through some of these strategies in the next few slides. So how do we improve our patient selection? Where there actually is bias in the way my physician colleagues think about people's candidacy for transplant. And so we did a national survey on physicians' attitude for who's the right candidate for a transplant. And this was done through the National Marrow Donor Program. And what doctors looked at were the top three things mostly. They looked at what other medical conditions do you have? How are you from a functional point of view? And what is your physical fitness? They didn't look at things like life expectancy. They didn't look at things like mood and people's attitude. They looked really at comorbidity, functional status, and physical fitness. And they had a variety of cutoffs for what made somebody a good candidate. So some physicians thought you needed to be nearly perfect with a performance status greater than 90 out of 100 to be a candidate for transplant. That's simply not true. We looked at comorbidity, and I should have spelled out, this is the hematopoietic cell transplant comorbidity index. And it looked like some physicians said, if you have one other medical problem, you're just not a candidate. 2 or 3 and forget it. So physicians were somewhat biased against using, against offering transplant to a fair number of their patients. Another strategy that we can use to improve transplant outcome is to make the transplant a little bit safer, a little bit better. And here was a very simple study looking back at hundreds and hundreds of transplants that were done already, looking simply at the conditioning regimen. Which regimen is better? And if you just focus on the curve on the bottom, you see that very clearly individuals who receive regimen A with melphalan in it did better than individuals who received B, regimen with busulfan in it. A very simple strategy, just fix the conditioning agents and you'll end up with better patient outcomes. This was done specifically in patients with myelodysplasia and specifically who were older. Next, very important, how do we take care of the needs of our transplant patients who are older and who have specific risks of bad outcomes with transplantation? So this was a really nice program that colleagues at MD Anderson put together, which they called the Enhanced Recovery from Stem Cell Transplant Program. So this was, how do we prevent falls? How do we monitor for delirium? How do we make transplant a little bit better for older patients undergoing the process? This involved a very sort of soup to nuts approach involving patients prior to their transplant, what they called prehab, getting patients involved in exercise, sleep hygiene, getting a physical therapist involved before the transplant, getting a pharmacist involved to make sure the medications were optimized and patients weren't using medications that could influence their cognition, getting a nutritionist involved, making sure that patients were well, they were at their best body they could be prior to transplant, making sure they were fully, had their nutrition needs assessed. And during, before, and after the transplant, nursing was involved as well. And so they looked at a number of patients who they applied this program to, 64 patients. They also looked at 140 patients who were transplanted just before this program started, all right? So between 2015 and 2017, when this didn't exist, that was the control group. And then they piloted this program for exactly 1 year, and all 64 patients who were transplanted in the next year went through this program. And here's what they found. Very clearly, the patients who had this intensive assessment of older patients' needs simply did better. It was not because myelodysplasia or leukemia or whatever came back less often. It was because these patients tolerated the transplant better and had better outcomes for that reason. So this is an example of a very targeted intervention that can improve outcomes in older patients undergoing transplantation. We're getting down into the weeds here, but this is some evolving data that's coming out of our institution from Dr. Coleman Lindsley, who runs a tremendous lab here. And he looked at the genetics of patients with myelodysplasia. And what he was able to show was that a significant number of patients had unrecognized diseases when they were labeled as having MDS. And the most important was the one in the middle called a telomeropathy. And for those of you who are familiar with the bone marrow failure syndromes, telomeropathies are diseases like dyskeratosis congenita. And so in a patient group of older individuals with MDS, a significant number had unrecognized or form-fruste dyskeratosis. And for patients with that form-fruste of dyskeratosis who underwent a myeloablative transplant, they had the highest rates of morbidity and mortality when they had high-intensity chemo. No difference when you have low-intensity chemo, but what this tells us is that patients who have these unrecognized diseases should be shunted towards reduced intensity or reduced toxicity transplantation. And this would help a significant number of patients with these unrecognized diseases. And this is data that's forthcoming in JCO in the coming months. So we've spent about 30 minutes on myelodysplasia. I'd like to take the next 10 minutes or so to talk about aplastic anemia, which is, as you know, a far less common diagnosis, but equally important, particularly for those who are affected. And the interesting thing about aplastic anemia is that it is possible that the first bone marrow transplant in North America was actually done for aplastic anemia. And this was a report from 1940. In this report, the physicians here, Drs. Morrison and Samwick, injected a few cc's, we're talking teaspoons of bone marrow, directly into the breastbone or the sternum of a patient who had aplastic anemia, probably on the basis of a chemical exposure. And turns out the patient recovered probably because their bone marrow recovered, not because they actually were able to reconstitute their entire blood volume with a few cc's of marrow injected into the sternum. But just an interesting historical note. And my mentor and boss, Dr. Joseph Anton, loves to show this slide because this happened at the hospital he was born at. So as opposed to the numbers that I've shown you for myelodysplasia, where outcomes were at best 50%, here in aplastic anemia, success is the rule. And so if you are a young person having a transplant for aplastic anemia with a matched sibling, you're looking at 85+% long-term outcomes. Less good for individuals who need unrelated donors as you move down these survival curves. But I think it's obvious that these curves are a whole notch above what we saw before for myelodysplasia. The more recent you are being diagnosed with aplastic anemia, the better people do. So this analysis looked at outcomes before and after 2004. And I can tell you that if you do this analysis again, looking at patients diagnosed before or after 2010 or 2015, this top curve keeps going up. So this was 83%. It probably approaches 90% now. We've learned a lot of things about doing transplants for aplastic anemia. This is the one disorder where we absolutely 100% always do transplants using bone marrow rather than peripheral blood stem cells. The reason is that there is far less chronic graft versus host disease and therefore far better overall survival. Whereas in diseases like MDS and leukemia, where some amount of GVHD might be a good thing because it might help eradicate tumor, there's no tumor in aplastic anemia, and so there's absolutely no advantage of having any amount of GVHD. So using bone marrow in this disease is 100% the rule. In unrelated donor transplant, things have gotten better. We've learned how to suppress immune systems better. This was one analysis that looked at simply by including small doses of the antibody drugs ATG or Campath, one could markedly improve outcomes. And again, this is actually older data. This is 2000 to 2015. And so the numbers are probably even better today. And then the most recent thing our field has done is looked at a way of getting rid of some of the conditioning intensity and making transplant a little bit safer by lowering the amount of chemotherapy one gets at the time of transplant. And so as opposed to the curves before, where the curves fall with survival, this is an incidence curve. So this is a cumulative incidence curve of bad things happening. And so here you want to be the red curve, not the blue one, because it implies a lower incidence of bad things like graft failure or morbidity there. And here, the traditional way of looking at it with survival is that in this very contemporary group of patients who received a lower dose of chemotherapy, 50 milligrams of cyclophosphamide per kilo rather than 100, survival here, probably if you had to estimate, it would be, what, 95 to 97%. So this is a tremendous, tremendous advance in outcomes in transplant. Of course, this is a clinical trial. Clinical trial results are often better than the real world, but this is an extraordinarily encouraging curve to see that almost no mortality in the modern era with aplastic anemia. Now, not everyone is going to have a donor available, and in recent years, we've started using what we call haploidentical transplantation. Cord blood and haploidentical transplantation have really opened the field up to almost all individuals who need a transplant. A haploidentical transplant is a half-matched transplant. And so half-matched family members include parents, children, and about 50% of your siblings will be half-matched to you if you don't have a perfectly matched donor either in your family or in the unrelated donor registries. And the reason why I show these curves is because they are very encouraging with results that are very close to matched transplant. And so now we're actually even recommending transplant for people with aplastic anemia who do not have fully matched donors because the outcomes are very, very good and are only going to get better with time. So some of the evolving themes in aplastic anemia transplantation: early transplant is associated with better outcomes. We now think about doing rapid, unrelated donor transplant as frontline therapy for appropriate candidates. So it used to be frontline only if you had a matched sibling, but now if you have a perfectly matched unrelated donor, we would consider that really almost equivalent, and we would recommend early transplant rather than trying immunosuppressive therapy. And then finally, half-matched or haploidentical transplantation is now a very valid and very important evolving option for patients who don't have suitable matched donors. With that, I believe comes to the end of the formal part of this presentation. Again, I'm very happy to take questions and want to thank Julie and Lee for inviting me to speak here today.
Well, thank you so much, Dr. Cutler, for the wonderful presentation. We do have some questions. Our first question reads, are low-risk MDS patient candidates for transplant? If so, is there similar data available regarding quality of life?
So I'll answer the second part of that question first. So the quality of life issue, I don't think has been asked properly in lower risk patients. When we did the study here at Dana-Farber, what it showed was that for high risk patients, outcomes were better with transplant. For low risk patients, outcomes were about the same. What that means is that it becomes patient and physician choice, right? So no one would choose an outcome that was worse. So if I told you transplant was worse, you wouldn't choose that. But if it's an equal outcome to not having a transplant, with the possibility of cure down the road, then some people would choose the upfront risks associated with transplant for the downstream effects of cure. And so for the appropriate low-risk MDS candidate, people who are very heavily transfusion dependent, for example, those are people who we would consider transplantation if the patient was motivated. It turns out that low-risk MDS patients do better than high-risk MDS patients because they have a very low chance of having their MDS come back. So it takes that out of the equation to some degree.
Thank you. This question comes from a patient with mild or moderate aplastic anemia who has a sibling that is a bone marrow match. Should they consider a transplant or wait until their aplastic anemia becomes severe?
Well, that's a tricky question to answer because I would need to know to what degree they have aplastic anemia. As you know, it comes in different degrees, and some patients may never require a transplant. So without knowing some specifics, I'm not sure I can actually answer that question.
Okay, thank you, Dr. Cutler. Our next question is, would you consider someone who is between the ages of 75 and 80 with good health okay for a transplant?
So I would, and I have. So I have transplanted individuals in that latter half of the 8th decade. Again, it comes down to comorbidity, physiologic age. So is this someone who's out walking a few miles a day and is very active and has a good social support to get through transplant? We wouldn't use age alone as a criteria for the transplant, but we would look at the whole patient and their overall status. Are they frail, etc., and use that. So yes, they should be considered. Not many will be appropriate candidates, but some will.
Thank you. This question reads, for MDS transformed to AML, what does the data say about bone marrow transplants and their effect on survival? This comes from the patient was originally low risk MDS. Doctors suggested supportive transfusions. They converted to AML after 3 years.
So that's one of the unfortunate risks of MDS, is that there is a continuous risk of conversion to acute myeloid leukemia. Once MDS converts to AML, it's unfortunately not curable with chemotherapy alone. And so we would consider anyone who has what's termed secondary AML or AML arising out of MDS to be an absolute transplant need. So all of these people should be referred to transplantation. In the absence of transplant, that leukemia is unfortunately going to come back.
Thank you. There's a second part to this question. It says, why might an adult child not be suitable for bone marrow donation? They would like to donate to their father, but apparently they are not a match. I thought haploid identical matches were fine.
They are fine, but it is a matter of sort of prioritizing matches. So in our center, a perfectly matched sibling would be our first choice. A perfectly matched unrelated donor would be our second choice, followed then by a half-matched child. So while everyone has a haploidentical match, if they have a child or a parent, it's not necessarily the optimal match for that patient. And so knowing what else was in the registry for that patient would be the first question to ask. And then second is there's perhaps that adult child is not healthy enough or has an unrecognized health condition that makes donation not advisable either for that patient or for the donor themselves. So there's more to that than we know, but it's either a question of there's a better match out there or that donor is simply not suitable to donate.
Thank you. Is there any specific data on survivability for aplastic anemia patients over 65?
Over 65 is not a contraindication to transplant. In general, over 65, we would attempt immune suppressive therapy first. 65-year-old patients and older are unlikely to have a fully matched healthy sibling. So once you get above 65 or so, siblings tend not to be good donors. So there is data. I don't have a slide on it, but we certainly have performed transplant on older individuals when that's the appropriate medical decision.
Thank you. And is there any, this next question is there any data for multiple diagnoses if a patient has been diagnosed with PNH, MDS, and aplastic anemia?
Yeah, it's tricky because those three disorders often have some very overlapping features and often can coexist. So if you look hard enough, a small proportion of MDS patients will actually have PNH clones, and a small number of aplastic anemia patients will actually progress to develop MDS as well. So there's sort of a Venn diagram of PNH, aplastic anemia, and MDS, and there are a small number of patients who sort of meet the diagnostic criteria for two and rarely all three of those diseases.
Thank you. This question reads, what is considered heavily transfusion dependent?
I would say there are formal definitions and then there are informal ones. So for red cells, it's anyone who needs more than 4 units a month, so 2 units twice a month. Platelets, it's anyone who needs more than 1 unit a week, I would say. There are lots of clinical trials that define it differently, but I think it's also sort of, you have to answer this on a patient basis. The patient lives 2 minutes from the hospital, can go in every Monday morning and be in and out in 3 hours. That has a very different implication than someone who has to drive 3 hours, wait 4 hours for a cross match to be done, get a transfusion, spend the next few hours in the car, and a transfusion becomes an entire day event. So those have very different implications and might mean different things to different patients.
Thank you. Is there any evidence that diet can influence acute gastrointestinal GVHD?
So for acute GI GVHD, we always recommend resting the gut, particularly when the colon or the small bowel are involved. We don't think that there's an influence of what foods people eat before or after, although there's a very interesting and evolving field of the gut microbiome and how that influences the risk of graft versus host disease. I don't think we feel just quite yet that we can fix GI GVHD with either pre or probiotics or with live active cultures.
Thank you. This question comes from a low-risk MDS patient with refractory anemia with sideroblast. They have no matched sibling. They've been on Vidasa for 10 years with no other comorbidities. Any advice on when they should consider a transplant?
Well, here biology trumps all of these statistical models because this person's obviously done very well on Vidasa, and I probably would not rock that boat.
Thank you. Our next question, this is coming from a patient who is 74 with no comorbidities and does not require transfusions. They were diagnosed several years ago with low risk MDS, but has transitioned to more intermediate risk. The team did consider a transplant, but the patient was then persuaded that the risk outweigh the potential benefits. They're now having second thoughts. What is the latest the patient can consider going to transplant?
Well, there's no latest. You want to do it before it's too late, because once this transforms into high risk disease or acute leukemia, it is then too late. The transplant's less likely to work. If this person's having second thoughts about what they were persuaded, then I would say get a second opinion at a different center and see if another doctor would feel somewhat differently. That's all. It never hurts to reach out and hear multiple opinions.
Thank you. After transplant, can patients have biological children, or are those children considered natural children of the patient?
Well, depending on what type of transplant one undergoes, it might be sterilizing or put that patient into menopause, depending on their age and what conditioning regimens they use. Younger people who want to think about fertility preservation should really do that before they pursue transplantation. Those are discussions that have to happen before the transplant. Waiting till after the transplant, it might be too late.
But after people have a transplant, if they have children, are they still considered their natural children, even though they have a donor's
Yes.
cells? Okay, thank you. Are there any special considerations for transplant patients related to the COVID vaccines, specifically MDS patients?
There's nothing specific for MDS. At our center, we are recommending vaccination for all patients when they hit their 100-day mark. We chose the 100-day mark rather arbitrarily. It's what we use for influenza vaccination. We and others are studying the response to vaccines, and we might revise that recommendation in several months or several years. Patients who receive the vaccine before their transplant definitely are going to need to receive the vaccine following transplant as well, because that immunity will not last after the immune system is replaced.
Thank you. This question pertains to a 16-year-old male patient who's been diagnosed with severe aplastic anemia. He is currently covered under state Medicaid program, which requires that all patients go through ATG twice if needed before considering a transplant. Any recommendations? They are concerned that not going to transplant, or it may reduce the success of transplant, undergoing ATG twice.
I would agree with that. I would think about some advocacy avenues for that patient. I'm not a pediatrician, but my understanding is that outcomes are so good with transplant that really transplant should be considered up front. And that's the type of case where some sort of advocacy to try to get around those rules should be attempted.
Thank you. Does having a pacemaker impact the success of a transplant? Will they even consider a patient with a pacemaker for transplant? This question is coming from an MDS intermediate risk patient.
Yeah, we'll definitely consider a pacemaker. It is not a contraindication. Of course, it does count against comorbidity. So it does increase the likelihood of having complications from transplant, because this person clearly has arrhythmia. And so one has to think about that when determining their appropriateness. It's not the pacemaker itself. It's the fact that they have heart disease.
Thank you. Do you have any recommendations for an MDS patient, low risk, single lineage, with low platelets when Vidasa has already stopped working? Would you consider them to try another drug therapy, or would they need to look into transplant?
There certainly are other drugs out there for patients like that. There are two platelet-specific acting agents, L-trombopag and romiplastim, that could be helpful in that scenario. But certainly reevaluating the disease and making sure that nothing else has happened and it's not progressing is also a strategy they need to think about.
Thank you. If a patient is having a bone marrow biopsy and aspirate before seeking a transplant, what should they ask testing to be done? The patient says, what should I insist the bone marrow test should include?
I think in 2021, a comprehensive genomic analysis needs to be done. And that's when we look at individual genes that are known to be associated with outcomes in MDS transplantation. That should be a routine part of marrow assessment for all patients at this point.
Thank you. And Dr. Cutler, could you speak about the Rockstar clinical trial? And are there any other promising research trials to improve GVHD of the lungs?
Sure. So I prepared some slides because I thought this might come up, and I was warned this might come up. So the Rockstar study was a trial of a novel drug called belumosudil, which is a ROCK2 inhibitor and is being tested for chronic graft versus host disease. And we recently just presented the results of a large study looking at 2 different doses of this compound. And as you can see here, about 3/4 of the patients who received the drug in either arm had meaningful response rates. Patients, this is that same forest plot I showed before, that had received drugs like ibrutinib and ruxolitinib previously responded very well. And if you look here at the far right, there is a column that showed that about 1/4 of patients with GVHD of the lung actually responded to this agent. So this is a very promising agent for lung disease. There are a couple of other agents out there that are promising, but this certainly is one of the more promising drugs, and it's currently under evaluation by the FDA for approval, and hopefully we'll hear about this before the fall.
Thank you. And Dr. Cutler, if somebody was interested in any of the trials that you currently have going on, how would they reach out to you or contact through your office? What's the process for a patient who may be interested in the Rockstar trial or any other trials that you currently have going for GVHD?
Well, that trial itself is closed because the drug we've completed it. I think the best resource is the website clinicaltrials.gov, and you can just put in what you're looking for, so either MDS or GVHD, and it'll give you a list of clinical trials that are open, and you can search by region or by city, so you can find the transplant center that's closest to you and sort of reach out to the transplant offices there rather than having to travel to Boston.
Thank you. And Dr. Cutler, would hereditary iron overload be considered a comorbidity?
Yes, it definitely would. It doesn't actually, it's so infrequent that it doesn't make it into the scoring system, but hereditary hemochromatosis is definitely a comorbidity because we know that iron overload increases the rates of complications after transplantation. So I would consider it a comorbidity, yes.
Okay. And this question is, how forcibly should a doctor pursue encouraging a patient to have a bone marrow transplant if the patient has both severe aplastic anemia and MDS and is transfusion dependent?
It's always the patient's choice, but for someone in that scenario, it sounds like a transplant might or should be considered very strongly.
Well, thank you so much, Dr. Cutler, for sharing your time and your expertise with all of us today. If you would like to watch this program again at a later time, it will be available on our website 2 to 3 business days. If you have a question and it was not answered today, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, contact our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are here to help you and your family as we have done for the past 37 years. This concludes today's program. Thank you again, Dr. Cutler.
Thank you.